Okay, so the indication for mechanical ventilation are apnea or impending inability to breathe, acute respiratory failure, severe hypoxemia or hypercarbia, respiratory muscle fatigue, also uh, inability to protect one's airway, someone that's altered either through some kind of a organic problem like a stroke, or someone that's impaired with substance abuse. So positive pressure machines that we use just push positive pressure from the machine into the patient's lungs and then allows exhalation passively. There's different settings that we use. Assist control is a popular one, so AC, a certain rate, which would be normal, or set higher depending on the patient's CO2 and acid-base status. The higher the rate, the more CO2 we can get rid of from the patient. We set a tidal volume based on lung protective strategy, which is generally around 6 milliliters per kilogram of body weight. And then we set the oxygen based on the patient's need for oxygen. And a lot of times we'll use positive end expiratory pressure, or PEEP. The typical setting, starting setting, is +5 or PEEP, 5 centimeters of water pressure. So in assist control, every time the machine cycles, they get that set tidal volume. If the patient breathes above the set respiratory rate, they get the same tidal volume. There are many different nuances and settings that can augment the type of breathing the patient's doing, and different pressure release, volume control. There's just a lot of different kinds of settings which, for this purposes of this lecture, are not critical. But what we're looking at is good airway expansion of the lungs, that you hear lung sounds, and that you have good ventilation and good blood gas to support their life. Typical settings, let's say this patient in our case study in your PowerPoint is on a AC mode, set at 500. The oxygen is 50%, the respiratory rate's 18, and the PEEP is 5. So we would need to document those settings and make sure that they are on them, either looking at the machine, which you can learn in clinical, or asking a respiratory therapist. But as you work in ICU, you get more comfortable with this. Some of the more important alarms are the high pressure limit, usually indicating some kind of obstruction and generally mucus in the tube. Low pressure, where there's a leak in the system and that set pressure is not being achieved, or there's a disconnected line somewhere. Those are important ones. So you can go through the slides through the 60s, and they talk about pressure controlled inverse ratio ventilation, not used very commonly anymore. PCIRV, airway pressure release ventilation is used. So these are lots of different what we call modes of ventilation. The reason behind PEEP really is to increase the availability of oxygen to diffuse through the alveolar capillary membrane into the pulmonary artery. So I'm looking for other slides here. Nitric oxide on slide 78 helps to improve the diffusion of gas from the patient to the bloodstream, or from the ventilator to the blood, and helps oxygenation. Prone positioning can be done in severe ARDS, and so we can what we call recruit the posterior alveoli. Extracorporeal membrane oxygenation is another support mechanism for pulmonary support to improve oxygenation. Complications can be pneumothorax, and that's treated with a chest tube. And sometimes we can overventilate people, but we ought to be able to discover that with an arterial blood gas. VAP, those are VAP guidelines on slide 89 are important. And the complications of positive pressure ventilation, you need to look through those. The psychosocial needs of these patients are quite high. They need to be supported. If they're not, they're largely sedated and have analgesia, but they need a lot of support, and they need to be interacted with frequently. If a ventilator does malfunction and you don't know how to fix it quickly, the best thing to do is grab the bag valve mask or the amber bag and disconnect the ventilator and bag the patient. Make sure that the oxygen is connected and on. And that, if you're calm, it only takes a few seconds to do that. Nutritional therapy is important too for ventilator patients. They need nutrition for energy. And then weaning really occurs when everything is resolved and the patient is as alert as possible, breathing well on their own, lungs are reasonably clear, chest x-ray has resolved, infectious processes has begun to improve and get better. And so we do what we call spontaneous breathing tests where they're breathing pretty much on their own. And then we get them extubated.